Hello, everyone, and welcome to another webinar co-organized by A&T Neuroeducation. My name is Greg Acaturo, and I am the Director of Marketing at A&T Neuro. And today we're happy to be hosting this webinar and pleased to be joined by our presenters, Florence Hanard and Dr. Hendrik Kajosch, who will be presenting examples of EEGs and ERPs in psychiatry, along with some of the issues associated with that. Both of our presenters practice in the psychiatry Brugmann University Hospital in Brussels. Florence Hanard is a neuropsychologist and cognitive behavioral therapist, currently working as a neuropsychologist specialized in electrophysiology and collaborating with the Laboratory of Addictology and Medical Physiology Psychology at the University of Brussels. Dr. Hendrik Kajosch is a psychiatrist and analytic therapist specialized in the field of addiction and electrophysiology. He is also currently working on a PhD thesis on the evolutionary aspect of P300 ERP components in psychosis at the Laboratory of Addictology and Medical Psychology of CHU Brugmann. So, before we get started, I'd like to thank both of you, Florence and Hendrik, for being here with us today. And at this point, I will turn the screen and the stage over to you.
Okay. Thank you very much, Greg. We have the pleasure to talk today about EEG and ERP in psychiatry, and this in the clinical context where we are using these tools.
Okay, first we'll start with an introduction, which is common for EEG and ERPs. Then we'll talk about the use of EEG in psychiatry, then the use of ERPs in psychiatry, and we'll finish by some take-home messages.
Okay, we would like to start with some basic thoughts which we have in mind in our work in electrophysiology, and which are, in my eyes, quite important. One of the aspects is that psychiatric disorders are often combined with cognitive difficulties. And with this cognitive difficulties have electrophysiological correlates that we can identify by evoked potentials. Some of these ERPs can be considered as a marker of psychiatric disorders.
Okay, so why do we have an interest in electrophysiology in psychiatry? It's from the perspective, of a global approach of psychiatric care. Also, we know that currently the relapse and recurrence rates are tremendously high in psychiatric disorders, and then these psychiatric disorders can be associated with cognitive disorders. So we think that the identification and care of these cognitive difficulties may have a positive impact on the quality of life, as well as on the psychological symptoms, and can be a predictive indicator of patients' evolution. Also, it's in the context of a multidisciplinary approach of the diagnosis and treatment of psychiatric disorders. We see it as an add-on tool in first the differential diagnosis, for example, to rule out an organic cause for EEG and to observe some markers specific to some psychiatric conditions. Also, it's useful for the patient's follow-up because taking into account cognitive difficulties linked to psychiatric disease allows us to assess the evolution of patients' cognitive profile for specific function at the behavioral and electrophysiological level before and after patient's care. So it's a retest evaluation. Sorry for the noise.
Okay, so some other aspects which are in our eyes quite important about electrophysiology in psychiatry. We can talk about procedures which are very easy for the patient, even for patients which are not in a good state, it's to say which are in a psychotic state or in a state of deep depression. So it's not invasive. It's a procedure which is quite fast and easily disposable. And one aspect which is also quite important, it's about examinations which are not expensive, which is in our times also an aspect which is important. There is one issue which is characterizing, in my eyes, electrophysiological examinations in psychiatry, and this is the temporal resolution of it. There is no other technique which is disposable with this quality, and well, we are trying also to illustrate the value of this aspect.
And this high temporal resolution is really important for us because for ERPs, it allows us to easily different steps of information processing. So from the perceptive to the cognitive level, and to identify altered process on amplitude or latency with precision. Also, it allows us a quick evaluation of different and specific cognitive processes as decision making, for example, or inhibition. The ERP battery that we use, I will explain later. The duration of this battery is around 45 minutes, so it's faster than a complete neuropsychological evaluation. And also, it's easily doable for patients with more severe psychiatric conditions, for example, schizophrenia. Also, it allows us to observe cognitive difficulties that cannot already be observed at the behavioral level, so in task performance.
Okay, so just what are we concretely doing with electrophysiology in psychiatry in our hospital or our service? We are using it on a diagnostic level and also on a therapeutical level. So on the diagnostic level, we are using EEG, quantitative EEG, and the battery of evoked potentials. But there is also the aspect of therapeutic issues. We are applicating transcranial direct current stimulation. There is also neurofeedback, which we are using, but at this moment only in a research context. And well, one very old tool, but which is still quite important in some conditions, rather very severe psychiatric conditions. It's electroshock therapy, ECT. So, in summary, what are our activities in our lab? Well, we use an electrophysiologic assessment for specification of a differential diagnosis, for the therapeutic approach, and for patients' profile evolution. So, about EEG, some issues. Well, EEG is not always interesting for every patient, but for some clinical situations, like a first manifestation of a psychiatric disorder without any antecedent. For example, a patient who is presenting a first episode of psychosis at the age of 50 years, or in another situation where we are confronted with a typical presentation or evolution of a pathology. So it's in essential also very important to exclude organic problems in those situations, like neoformations, structural lesions, head trauma, endocrinological and metabolic disorders, infection, and also naturally epilepsy. It's also something, the EEG is also quite important in some differential diagnostic contexts. I resumed them here a little bit, but there are more. So it's always interesting when to think about temporal epilepsy when we are confronted with psychotic disorder presenting auditive and visual hallucinations, or also sometimes certain situations of a dissociative disorder. It's always important to keep in mind that temporal epilepsy has a quite similar presentation, but the treatment is completely different. In the older patient, it's sometimes very difficult to make the differentiation between dementia and major depressive episode. And well, the EEG is a helping tool. It's not something which gives us absolute values, but it helps us also, because normally also in dementia some alterations of the basic tracing. In the situation of acute confusion, it's a quite important tool to make differentiation between intoxication, neurodegenerative, metabolic, and endocrinologic disorders. Well, an urgency situation which is very important is to make the difference between the state of a catatonia, which we see in schizophrenia, and status epilepticus. So again, the treatment is completely different, and the status epilepticus should be treated by a neurologist with anti-epileptica, and the schizophrenia should be treated with neuroleptics by a psychiatrist. In alcohol dependency, the EEG allows us to differentiate acute withdrawal syndromes from subacute encephalopathy and epilepsy. Voila. And
so here we see a normal EEG.
Well, I'm just explaining how we are reading it. It's a monopolar registration of a normal EEG, and in the black lines you're seeing the left hemisphere, and in the blue lines it's the right hemisphere. The red lines are representing the central derivations, and the green lines are the occipital derivations, which are showing us the alpha basic rhythm, because the patient is presenting at this moment a state of with closed eyes. I'm just showing one slide for a patient we have seen a neuroservice and who has been hospitalized by the urgency servants in the beginning in the situation of a status epilepticus. A patient which was taking neuroleptic treatment because he needed it. He presented also psychotic symptoms. And this is an example how we try to find a compromise between the anti-epileptic treatment, which is necessary for this patient because he presents also epilepsy, and then the psychiatric treatment, which is inducing rather epileptic activity. So EEG in this context is quite important to monitor the well-being of the patient and to evaluate, to have some supplementary information about the clinical situation of the patient. Okay. Well, but can we conclude about EEG? It's quite important to think about EEG not in terms about that it should be normal or abnormal. A lot of EEGs, even I think about 50% of the EEGs we are seeing in psychiatry are not completely normal, but this is not really the issue. It's very important that it contributes to the diagnostic and therapeutic issues, and the contribution is depending on the clinical information which is disposable for the person who's interpreting the tracé. So it's quite important to have an idea about the diagnostic hypothesis, the treatment, and the recent clinical context to be good, to be able to interpret the EEG and to give an information about this tracé, which is helping the clinician who is asking for it. Okay.
So now I will talk a little bit more about ERPs. Just a quick reminder of how we are doing it. So ERPs are derived from EEG activity by signal averaging. So we take EEG segments linked to a specific event associated with a defined process, cognitive or perceptive process. So what we do is that we use a superposition of all the trials, all this part of the tracé, and it allows us to observe the ERP component. Okay, so these potentials are defined by their latency, so the speed of the neuronal recruitment, their amplitude, so the extent of the neuronal recruitment, their polarity, positive or negative. If, for example, so positives up and negativity is down, and we see a positive here component, P300. And they are also defined by the localization of the scalp through the topography. Okay, so what are we currently doing here in the lab? We use, in fact, an ERP battery. And this ERP battery has been created by our team with collaboration with Professor Campanella, which is the main researcher in the research part of our lab, and the collaborators of NT Neuro. And why do we use an ERP battery? In fact, well, it's because there is a low clinical benefit of the analysis based on a single component. In fact, there is a lack of specificity. For example, the P300, which is the most studied component in electrophysiology, can be altered, modulated, affected by depression, but also by bipolarity, schizophrenia, and alcoholism.
Mm-hmm. So this is quite a very important issue, because there's a lot of criticism about the utility of ERPs and also EEG in psychiatry, because you can take which psychiatric patient and you can say, well, he's showing alterated potentials. So what is the information about this? Well, a lot of neurologists are thinking in this way, and also psychiatrists, and the instances which are reimbursing the examination. So this is our issue today, to explain that it is very important to put together different components of ERPs and to see them to create a kind of a profile of the patient, which we are evaluating in optimal circumstances in two situations: in the beginning of a treatment intervention and after it, and to compare the situation. And so we can really show a very individual profile of the patient, which is contributing to the clinical context of the patient.
Okay. So why this battery? Well, there is an advantage of an approach based on the analysis of several clinically relevant ERPs, as Hendrik said, and analyzed at the same time in the same person. Also, for the interest of analysis that encompasses both the electrophysiological and the behavioral levels. By that, I mean that we don't analyze only the ERPs, we also take them into account with the behavioral level, so the performance of the task. The interpretation is always taking into account both behavioral and electrophysiological level. Okay, so, well, what do we have as tasks in our battery? We have two cognitive tasks. The first one is a novel task. It's a novel bimodal task. By that, we mean that there is sound and images. For this task, there is three kinds of trials. The first one is frequent. The second one is deviant, which is the one for which the patient has to press on the button as quickly as possible, as fast as possible. And also there are disruptors for which the patient is not aware of their presence before the task. So it creates a novelty effect that I will talk about later. The second task that we use for cognition is a bonobo task, which is also a well-known task for inhibition. Here, the patient has to press as fast as possible when he sees the letter M here, and refrain himself from pushing on the button when he sees the letter W, which is difficult because he has a tendency to press on the button because of the goat trails. So it allows us to observe inhibition. On the perceptual level, we have two tasks. The first one is a notable task that's inattentive auditory, so it's different from the other audible tasks I just talked about. For this task, the patient is in fact watching a movie. And what he has to do is really to be focused on this movie, and at the same time he has earphone. There is no sound, of course, in the movie, so the sounds that he hears are really different from the movie. And there are frequencies and deviance. And the deviance are a little bit longer or a little bit shorter than the frequencies. And I will explain later the integration for this test, but it's linked to mismatch negativity. And so the last test that we use, it's based on what we call Friedman's paradigm. It's also called period-click paradigm. It's in test in which the patient has to be attentive, to pay attention to the sound that he heard in the earphones, and he hears a period of click, so period of sounds, and the two sounds are the same. Okay, so what is in fact the interpretations of the task in the ERPs we are analyzing? For the bimodal oddball task, we are analyzing for the distractors the P3E, which reflects the novelty effect and attentional orientation process. For the deviance, so the item for which the patient has to press on the button, it reflects context updating and decision making. For the Gonogo task, we analyze on the Nogo trails first the Nogo N2, which is more linked to cognitive inhibition. We also call it conflict monitoring. So it's the fact that the patient really see the Nogo trial and understand that it's a trial for which he won't have to press on the button, so he will have to refrain himself from pushing it to the button. And the Nogo P3 is more linked to motor inhibition, so it's really the motor side of the inhibition, the fact that it doesn't press on the button. For the perceptive task, we have for the inattentive auditory task, the mismatch negativity, which is also a famous component in the electrophysiology, and which is known to reflect automatic detection of the deviance. So it's pre-attentive processing because the patient is not paying attention to the sounds, but is watching the movie. So it's not conscient attention, I will say. And for the last task, we are evaluating P50 sensory gating, which is also a famous process in electrophysiology. So, in fact, sensory gating allows us to filter irrelevant information in the environment, because the first sound and the second sound in the period-click paradigm are the same. We will see a normal P50 component for the treatment of the first sound, but normally there will be like an inhibition process in the brain, and the amplitude of the second, the P50 for the second sound will be lower than for the first one. So there is what we call a sensory gating. Okay, so I wanted to show you a clinical example of this. So here we have a patient of 66-year-old, which is retired. He has been here in our hospital for an ambulatory follow-up. He has been diagnosed with major depressive disorder and got for treatment, which is mainly psychotropic medication. And also what is interesting here is that it's a test-to-retest assessment. So this means that we have, he has the battery, ERP battery before and after the treatment. Also, what we can already say about this patient is that he has noticed mild improvement in his mood and other associated symptoms after the treatment, for example, in sleep and appetite. And also on a psychometric level, we used the Beck Depression Inventory, second version, and we've noticed that the score was quite high at the beginning and was still significant, but really lower at the end of the follow-up. If we take a look at the oddball test, what we can see is that there is a delayed reaction times in both timing, but the patient is faster in retest. If we take a look at the electrophysiology, here you have what is going on the deviance. So really when the patient has to click on the button in the decision-making process. We see here in plain line the first evaluation and in dotted lines the retest. And we see here the P300, P3B. We see that there is more neuronal resources allocated to decision-making in retest, which is a famous effect when there is an evolution of the mood of depressed patient in the literature. And we take a look about what is going on the distractors. So when there is this item that the patient is not aware before the task that's appearing on the screen, which creates a novelty effect, so the P3A, we see that there is also more neuronal resources allocated to this process in retest. When we take a look at the Gonobo task, we see that the performance in inhibition is nice at the beginning and even better in retest, but that the patient is still delayed for his reaction time in both timing and a little bit even longer in retest, which is logical because inhibition is better. So if the patient is slower in task, it gets more time to prepare for inhibition, and so it's logical that inhibition is better in retest of this condition. So we have to keep in mind that inhibition is okay for this patient, but as long as he's slow in the task. When we are looking at evocate-related potential, here we have what is going on for the novotrials, so when the patient has to inhibit dissonancy to push on the button. We see here for the NovoN2, which reflects, as I said, conflict monitoring, that there are more neuronal resources allocated to this process on retest, so here in dotted lines, and less neuronal resources allocated to motor inhibition in retest here, which is logical because there is a shift in strategy. When we take a look at the perceptive task, here we have a signal which is a little bit artifacted for the mismatch negativity, but we can see it here clearly. So again, plain lines are the baseline, first evaluation, and dotted lines, the second evaluation. We see that the amplitude of mismatch negativity is lower in retest and not satisfying. And then for the last task, P50 sensory getting, we have here two different pictures. The first one is for the first evaluation, and the second one for the retest. And here we see in blue the treatment for the first sound, and in red the treatment for the second one. We see here that there is even more neuronal resources allocated to the treatment of the second sound than for the first one, which is not a correct sensory getting, so it's not satisfying at first. But when we are looking at it and retest, we see that both the P50 are satisfying, and that we have clear here P50 sensory getting. We see that the P50 is normal for the first one, and that there is low neuronal resources allocated to the treatment of the second one, the second sound, sorry, here in the retest. So there is this sensory getting, the information is not relevant, so there is less neuronal resources allocated to this treatment. Okay, so that's nice, but what can we say in summary for this patient? Well, first is that there is an improvement of the patient's clinical condition in retest in a subjective and psychometric way. For cognitive task, we see a decrease in the delayed reaction time for the overall task, which is still low, but it's decreased in retest, with a little bit more neuronal resources, allocated to the decision-making process, and so P3B, and novelty effects, so P3E. We also see an improvement in the number of novotrials inhibited in retest, but a persisting and slightly accentuated delay in the reaction time in retest. We see less neuronal resources needed for the motor side of inhibition, a little bit more for the neuronal resources needed for cognitive side, but as I said, it's kind of a balance, because if you allocated more neuronal resources for conflict monitoring, that you will need less neuronal resources normally to treat motor inhibition.
So for the clinical situation, as I understand it very good, is that the patient is better, but not really completely good, and this is a quite important issue to be transmitted to the clinician who is seeing the patient.
Yeah, and I was going there with this hour there. I just want to say also that for the perceptive task, there is an improvement in sensory getting, which is satisfying and retest, but a slight decrease in neuronal resources allocated to early attentional orientation process, so the mismatch negativity. So at the end, what can we say about this profile? That there is an improvement of the cognitive and electrophysiological profile on retest, but it's not yet completely normalized. So it will be efficient, as we said, to be continued in a way that clinician has to pay attention to the cognitive profile and the evolution of this profile, and of course the psychological profile after the treatment. So what are the conclusions for ERPs? Because of course this was an example, but there are plenty of possibilities and things that you can observe. So those potential allow us to observe and report the patient's cognitive functioning at a given moment. Why do we do that? Then, well, first to evaluate a diagnostic hypothesis, but always based on the clinical level. We can also highlight electrophysiological cognitive difficulties. And also highlight cognitive vulnerabilities that are not yet observable at the behavioral level. For example, inhibition. For example, we have here in our hospital a clinic for patients which are wondering about their alcohol consumption. There is no alcohol dependence for those patients, but they are asking themselves, okay, is my alcohol consumption, does it have an impact on my health and so on? And we see, for example, that they perform correctly in the Gonoko task, but sometimes we see some vulnerabilities in the process of inhibition, for example, in motor and/or cognitive inhibition. We see that they need a lot of neuronal resources to do the task, so it's a marker that it can be a vulnerability, and that we can observe it now at the electrophysiological level, but that after it could have an impact on the comportamental level in inhibition.
So it's a tool which allows us to identify patients which have a higher risk to develop also psychiatric diseases, yeah, and also in the dependency problematics.
And also, as well, the example I just showed you, to monitor the evolution of patients' cognitive profile at the end of a treatment and thereafter, according to the clinical opinion. So it's test-retest assessment. What is also important to understand is that the interpretation of ERPs is done with regard to the clinical profile level, and the evaluation is intended to be a complementary, so an add-on tool to the clinical opinion, and is not by itself only without any clinical information a diagnostic tool.
Well, I think that you got our message a little bit. We are very convinced about the utility and the use of EEG and ERPs in psychiatry. We think that they have a lot of potential and that there are still things which have to be developed. And it's really just it's about tools which are very complementary to the clinical context, helping us in the context of a differential diagnosis, but also in the follow-up of a patient to understand topics which we can't just see on a behavioral level, but on an electrophysiological level. It's important to take into consideration that just the combination of different ERPs, so the battery of ERPs, and also the EEG, which allows us to contribute to the comprehension of these issues, to say the diagnostical questions and the evolution of psychiatric pathologies. Thank you very much.
Thank you for your attention.
Thank you, Florence and Hendrik, for sharing your interesting and important work and your experiences at Brugmann University Hospital.